Good day, all. Welcome back to the spinal cord injury lecture series. We're picking up where we left off last time. We had talked through the acute management of spinal cord injury. We talked a little bit about bracing and things that would get started in acute rehabilitation. Now I'm going to pick up and continue on with the comorbidities associated with spinal cord injury, both acutely as well as chronically. So my objectives, basically to review pathophysiology of the spinal cord injury, not to the extent that I had done previously. We'll talk about the influence of the somatic and the autonomic dysfunction on essentially the comorbidities of spinal cord injury. So this will provide the basis for the foundation of upcoming lectures. So as a reminder, the central nervous system is comprised of the brain and the cord. As we look at different levels of spinal cord injury, we see that it will affect more or less motor and sensory function. As you go down the cord, the person will have a greater amount of muscular function and sensory function as we go through there. But we also recognize the influence of the autonomic nervous system on the comorbidities, particularly because of sympathetic blunting and the fact that we now have parasympathetic dominance. So what that means is when you have an injury to the cord at or above the level of the about T6, you're going to have some degree of sympathetic blunting. And remember that there's a constant tug of war between the sympathetic and the parasympathetic nervous system. Because of the spinal cord injury and the subsequent dysfunction of the sympathetic nervous system where it arises in the cord, you're going to have profound influence in this parasympathetic dominant system. So we'll see reductions in heart rate, blood pressure. There will be influences on the respiratory, on the genitourinary system, on the gastrointestinal system, etc. So these are the typical comorbidities associated with high spinal cord injury, particularly those with tetraplegia, meaning all four limb involvement. They may have these. Now, typically, we wouldn't have an amputated limb. However, our folks are at high risk because of their low blood pressures and because of the fact that they can develop gangrenous ulcers and whatnot, so that they are at higher risk for amputations. But typically, and we'll talk through these briefly, we see an anabolic deficiency, parasympathetic dominance, as we mentioned before. We're going to talk through autonomic dysreflexia, but they're at higher risk for contractures because of spasticity. They have neurogenic hypotension and a relative bradycardia, as well as a neurogenic cardiomyopathy. Our folks with high spinal cord injury will have both neurogenic restrictive and obstructive lung disease. We'll talk through those a little bit more. Neurogenic bladder, typically with the trusor sphincter dysenergia, although if the lower portions of the cord and the cauda equina are involved, then you'd simply have a flaccid bladder and a flaccid sphincter. You can have neurogenic bowel, again, upper motor neuron or lower motor neuron, depending upon the level of the injury. Folks are at high risk for pressure injuries and neurogenic skin, neuropathic as well as nociceptive pain. They're at high risk for obstructive sleep apnea, heterotopic ossification, osteoporosis, and osteopenia. Because of the, again, neurogenic dysfunction, they are at risk for pelvic obliquity, scoliosis, and truncal instability, with skeletal abnormalities, including requirements for girdle stone procedures, for example, at the hips. We mentioned briefly, but spasticity or a flaccid paralysis may be present. That's going to be at lower levels of spinal cord injury. Sarcopenia is essentially loss of muscle. Typically, we're going to see an upper extremity overuse syndrome as they age through their spinal cord injury. They're at high risk for venous thromboembolism and for obesity and metabolic syndrome. So we're going to talk through each of these. And essentially over the course of the fall and winter, I will be doing presentations on each of these main topics. So pulmonary dysfunction, again, associated with parasympathetic dominance, bronchiolar constriction, and mucus secretions. Our folks with spinal cord injury are going to be at high risk for both neurogenic restrictive and neurogenic obstructive lung disease. Remember that the muscles of respiration include, for inspiration, the diaphragm, internal intercostal muscles. The accessory muscles include sternocleidomastoid, the scalenes, and the trapezius. But then as well, for expiratory function, folks require the use of the abdominal muscles, the rectus abdominis, transverse abdominis, internal and external obliques. We know that part of the dysfunction that occurs that's related to the neurogenic dysfunction or the neurogenic restrictive dysfunction is because of abdominal muscle paralysis. So a normal individual with fully intact motor function, when they go to contract the diaphragm is up here, domed, because the abdominal contents are being held in by the abdominal muscles. And therefore, when you contract the diaphragm from its resting length, you get a fairly good tidal volume. Those with paralyzed abdominal muscles, however, are going to essentially change the resting length of the diaphragm so that when they go to contract it, they have a relatively small tidal volume. So they're going to have shallow breaths and require more breaths per minute just to maintain their ventilatory function. We can counteract that with a very expensive high-tech device called an abdominal binder. And yes, just putting the abdominal binder on does compress the abdominal contents and causes the diaphragm to regain its original resting length, so that when you contract simply by having an abdominal binder, you can restore the tidal volume to a greater extent. So I've mentioned it, neurogenic restrictive lung disease. This is because of somatic dysfunction. That's because of muscle paralysis, the intercostals as well as abdominal muscles. And these folks are going to have a low vital capacity with reduced total lung capacity, shallow breathing, as we mentioned, and reduced pulmonary compliance. So other examples of restrictive lung disease that you may know about: scoliosis, obstructive apnea, muscular dystrophies, and motor neuron disease. So the neurogenic restrictive lung disease, so autonomic dysfunction is also going to play in because of parasympathetic dominance. And this is actually going to affect the bronchoconstriction under parasympathetic dominance, as well as mucus secretion. So we're going to have to deal with those. Typically, we're going to use bronchodilators and mucolytic agents, but as well, oxygen administration as necessary. Frequent bronchoscopy is not ideal, so we would rather manage this differently. Typically, we see a fair number of complications, respiratory complications associated with spinal cord injury, and the acute indications for ventilator management are listed here. Again, we're going to have a whole separate lecture on this as we go through. But the bottom line is, when I bring somebody over from the neurocritical intensive care unit, or even in the neurocritical intensive care unit, if I'm doing a consult, we're going to ask for around-the-clock respiratory management. And that's going to include nebulizer treatments, so essentially duonebs, and that's going to moisten the secretions and open the airways, followed immediately by postural percussion and drainage or vibration to shake loose the mucus that's there, followed immediately by mechanical inexsufflation to help clear the mucus from the airways within 30 minutes of the nebulizer treatment. If you wait more than 30 minutes, these secretions simply dry up and you end up with a mucus plug. So we also know that the parasympathetic dominance is going to significantly involve the cardiovascular system. So blunting of the sympathetic nervous system is going to have profound influences on the cardiovascular system, resulting in circulatory hypokinesis. What does that mean? When an able-bodied individual exercises with their upper extremities, they're able to maintain and actually increase heart rate and blood pressure as they increase workload. Those with spinal cord injury, particularly high spinal cord injury, however, lack the sympathetic tone in the lower extremities. They also lack a venous pump. So the muscles, the skeletal muscles themselves are paralyzed, aren't able to contract and push the venous blood back up through the inferior vena cava back to the heart. So, and also the reduced sympathetic tone is going to contribute to inferior vena caval dilation. So you got a lot more blood sitting essentially in stasis that's not returning to the heart. That's going to reduce the Frank Starling mechanism. So with a reduced left ventricular end diastolic volume, you're going to have a reduction in the contractility of the heart. And then on the other side of the system, the arterial side, you are reducing, we're going to talk about neurogenic orthostatic hypotension in a moment. So the bottom line is you develop an adaptive myocardial atrophy in response to a diminished afterload and a diminished preload. And then finally, you have blunted chronotropic responses because of the blunted sympathetic drive. The vagus nerve has almost complete dominance over the SA node at the heart, and so you see a relative bradycardia and or dysrhythmias that can occur as that is accompanied. So neurogenic orthostatic hypotension. Typically, we think about hypovolemic shock, in which you have a low blood pressure because of loss of blood volume, a relative hypothermia, and a tachycardia that is compensating for the low blood pressure. With neurogenic shock, on the other hand, because of the sympathetic blunting, your blood pressure drops, but you have a relative bradycardia because you don't have the sympathetic activation to compensate for the lower blood pressure. And so there are times when we have to actually implement cardiac pacing in the early stages of high spinal cord injury just to be able to maintain cardiac output. So management strategies, as we bring folks to acute rehabilitation, we're going to provide mechanical support, including the abdominal binder. Now it's compressing not just the abdominal contents in and up against the diaphragm, but it's compressing those abdominal contents as well into the inferior vena cava. So it closes that down and allows for increased blood return back to the heart. Elastic stockings, not TED hose, we'll talk about that at a different time, but the actual compressing garments that are going to increase the blood pressure and make sure the person is adequately hydrated. Pharmacologically, we can provide salt tablets. Typically, we would move on to Florinef, fludrocortisone, and or midodrine chlorides to help increase the total blood pressure and allow the person to participate in physical therapy and occupational therapy. Our folks acutely and chronically are at higher risk for venous thromboembolism, partly because of the hemostasis that I've already described. And yet in the early phases of acute spinal cord injury, they are also in a hypercoagulable state. And so we try to prevent venous thromboembolism by using low molecular weight heparin in particular. Occasionally we'll have to use heparin instead. And that depends on how complicated the person's course is. That would typically go at least 2 months or 3 months in terms of prophylaxis before we would stop the chemical coagulation, anticoagulation. Our folks are at high risk for autonomic dysreflexia as well. We're going to describe, actually spend a whole lecture talking about the autonomic dysfunction after spinal cord injury, but first reported back before the 1800s as a massive sympathetic outflow in response to a noxious stimuli below the level of injury in persons with spinal cord injury above T6. Complications include stroke, seizures, organ failure, and death. Essentially, you have a noxious stimuli below the level of the injury that ascends the cord. The afferent impulses are blocked, however, at the level of the spinal cord injury, and you get this reflex sympathetic outflow that causes splenic vasoconstriction and hypertension. That increased pressure is sensed and sent to the medulla that sends information back to the heart and causes a relative bradycardia. But below the level of the injury, the person remains vasoconstricted. Above the level of the injury, vasodilation, sweating, and a pounding headache we refer to as autonomic dysreflexia. So we coach folks early on to elevate the head if they are beginning to experience these symptoms. Loosen tight clothing and leg bags. Check number 1, the bladder, number 2, the bowel, and then look for other sources of potential noxious stimuli. Consider pharmacological intervention that looks like this. If it's an acute cause, typically we're going to be using nitro paste is our best way to manage this. If we find a source that we can readily remove, then we can also wipe off the nitro paste as opposed to taking an oral medication or even a sublingual medication that is not as easily reversible. For things like pressure injuries or bone fractures, etc., that it's going to take some time to heal, then we're going to have to prevent recurring episodes of hypertension. And we can use a number of different medications. Again, we'll have a whole hour just to talk through managing autonomic dysfunction after spinal cord injury. Neurogenic bladder is typically one of the most difficult things to manage after a spinal cord injury. Again, spinal cord injury, we're going to see a hyperreflexic bladder as well as sphincter, and that is called the detrusor sphincter dysynergia. If both constrict at the same time, then we see the urine backflowing through the ureters up to the kidneys and can cause acute hydronephrosis. So that is a major problem in that it can cause acute renal failure and potentially death. We also have to consider, again, in conus medullaris or cauda equina injuries, you're going to have a flaccid detrusor and likely a flaccid urinary sphincter. And so we're going to be managing that a little bit differently. Either way, most of the time, folks are going to need to do intermittent catheterization to manage their bladders. We need to be on the lookout, not so much acutely, but chronically, for issues of renal dysfunction associated with the detrusor sphincter dysynergia in particular. Folks with spinal cord injury who are not managing their bladders appropriately are going to be especially high risk for urinary tract infections, and bladder as well as renal calculi. Bladder management is going to be very, very important, therefore. And so we will talk through the appropriate screening to appropriately manage the bladder over the course of the person's lifetime. And specifically, we'll talk about specific screening measures. So typically an annual renal ultrasound just to make sure the kidneys are safe. And then intermittently urodynamics, usually every 1 to 2 years, to make sure that we're keeping the pressures down appropriately. Pharmacological management may include oral medications and or potentially botulinum toxin injection to the bladder and or sphincters. Neurogenic bowel is another major issue that we have to consider as we're looking at our folks with spinal cord injury. Like the neurogenic bladder, you can have either an upper motor neuron that is hyperreflexic bowel or a lower motor neuron, hyporeflexic bowel. The first one is going to have typically a tight sphincter, and the lower motor neuron is going to have a completely flaccid sphincter. So we've got to manage these two things differently. Folks acutely are at high risk for ileus, but they're also at risk for an ileus, which basically means the bowel stops transporting or propelling the fecal contents forwards through the GI tract. That can be caused by increased sympathetic drive. And you're saying, well, wait a minute, Dr. Gator, you just told us that these folks are going to have sympathetic blunting. Yes, except for those cases with autonomic dysreflexia, in which case the sympathetic nervous system can actually bring the gut to a relative stop, and hence the ileus. So we need to worry about that. Our bowel care is going to be different for upper motor neuron reflexive bowel. In this case, we're going to be taking advantage of everything that we can, including the gastrocolic reflexes. So as we distend the stomach, approximately 30 minutes later, you're going to see a contraction of the large bowel, the colon. And that is a reflex response that we like to take advantage of. We also are going to use chemical in the form of vesicodal suppository, ideally vesicodal in a polyethylene glycol base that will melt relatively quickly and cause a chemical reflex contraction of the colon. As well, we use digital stimulation. So actually insert the finger and stimulate the sphincters to relax and cause contraction of the lower GI tract, again, trying to optimize the full evacuation. We're always going to try to optimize the person's position to empty more completely. Having them sit upright on a padded commode would be ideal. Still need to have them upright if they have a lower motor neuron bowel, and recognize that the gastrocolic reflex is still intact even in that situation. However, the chemical reflex responses, the mechanical reflex responses aren't going to work if you've got disruption of the lower motor neurons. Remember, this is a flaccid paralysis. And so typically the person with the lower motor neuron bowel is going to need daily bowel care, and try to have a little firmer stool so that it's less likely to slip out. Much more information on this in that 1-hour lecture on neurogenic bowel. Our folks are also going to have some degree of sexual dysfunction after spinal cord injury. Now, the majority of folks with spinal cord injury are still men. And depending upon the level of injury, if the injury is at or below T10, folks can still have a psychogenic erection. That means they can be thinking about or looking at visual stimuli, etc., and that can cause an erection. But for a reflexic erection, basically this is going to require stimulation below. So this can't be a lower motor neuron injury. This is going to have to be an upper motor neuron injury so that the reflexes are intact. There is typically going to be a dysregulation between the emission and ejaculation, and oftentimes men will have retroejaculation, where they actually propel the sperm and semen back into the bladder. You can still collect that with, the next time that they do their intermittent cath, spin down the urine to be able to essentially separate it from the semen, and then potentially use that with ICSI or other types of fertility types of things that we can go forward. Women are going to have similar issues. They may be anorgasmic, meaning that they wouldn't be able to orgasm. Both men and women, however, realizing that this can be perceived by their autonomic nervous system as a noxious stimuli below the level of the injury. So sexual excitement, getting to the plateau, ejaculation, and or orgasm can also cause, in some cases, autonomic dysreflexia. So we need to be very careful, educate our folks how to do that. Recognize that while men are oftentimes infertile, women typically will regain their menses within 3 to 6 months after spinal cord injury, and so they can conceive as easily, it seems, as if they didn't have a spinal cord injury. But then we have issues that we need to contend with regard to their pregnancy, which is considered high risk labor and delivery, especially recognizing their increased risk for autonomic dysreflexia. The other thing with regard to sexuality, besides just the physiology, is the intimacy associated with communication, self-esteem, and those types of things. Oftentimes after a spinal cord injury, people feel as if they are not as sexual, cannot be as attractive as they were before. And so the psychosocial aspects of sexuality after spinal cord injury are very important to help our folks completely reintegrate back into their lives, back into the community. Again, I guess I don't mention this frequently enough, but managing spinal cord injury is a multidisciplinary practice. The physicians do play a role, as do the nurses. The therapists obviously play a role, the psychologists, huge role. And this is one of the reasons why they're going to be so important for us, but as well, simply adjustment to the disability is a big aspect of surviving and thriving after a spinal cord injury. So I didn't mention the social workers yet. Again, there is a huge team that needs to come together to really optimize life and optimize function after spinal cord injury. Our folks are at high risk for pressure injuries. You are high as able-bodied individuals. Typically, we'll do pressure relief every 30 to 60 seconds as we feel a little bit of tingling, for example, on the backside while we're sitting too long. Person with spinal cord injury is no longer getting those afferent signals. And so we have to train them to be especially disciplined in order to do pressure relief, whether that's being able to do a push-up pressure relief or leaning forward, shifting side to side in the chair. In bed, they need to be able to turn frequently as well. So a big part of pressure injury management is prophylaxis. So to the extent possible, the prevention of pressure injuries is what we're going for. And so that's going to have implications with regards to their mobility devices, whether or not they are able to do a complete pressure relief without a powered wheelchair tilt in space type of system. And so therapists and our skin specialists are going to be working closely together to optimize the type of wheelchair that is needed, but as well the wheelchair cushion. Did I mention education? Trying to help them to gain the discipline to do pressure relief frequently when they've never really had to worry about that in the past. They were just automatically, almost subconsciously, doing pressure relief before their spinal cord injury. We will talk through the classification of pressure injuries. They used to be called pressure ulcers. We've recently changed the nomenclature on that for specific reasons that we'll talk about. But this is a major issue for many of our folks with spinal cord injury, particularly those who are aging and may have gone 15, 20 years without a pressure injury and suddenly have their first pressure injury. We have to help them in the process, not just heal the wound, but determine what the etiology, why did they develop a wound 20 years out from their injury, and make sure that we are alleviating the contributing factors. So again, management strategies, primarily prophylaxis, but then we have medical and, yes, in some cases, surgical management, followed by rehabilitation and subsequently trying to optimize and reduce the likelihood that they will develop another injury in that particular area. Spasticity and spasms after spinal cord injury. So spasticity is velocity-dependent tone, meaning the person's muscle tone has increased. And the faster you move the limb through its range of motion, the more resistance you encounter. So this is essentially disinhibition of the reflex arc. Remember Sherrington's final common pathway. You have 1A afferents coming from muscle spindles, going to the cord, interacting with interneurons, and ultimately causing activation of the alpha motor neuron to that same muscle. That reflex arc is typically for able-bodied individuals is dampened. So there is an inhibition to keep our reflexes under check in most circumstances. After a spinal cord injury, that inhibition that comes from the brain basically is blocked. And so now those reflexes are essentially unchecked. And so they have hyperreflexia, often at the knees and ankles, and that can cause clonus, which is simply hyperreflexia on both sides of the joint. We have classification system for spasticity, as well as for spasms, which are provoked or unprovoked muscular contractions that cause limb movement. And we'll talk through different management strategies for spasticity, including modalities, pharmacological management, neurolysis, and in some cases, surgical interventions that are required. Again, trying to overcome the disinhibition of those reflex arcs. Now we've got these long track signs that we need to address. Our physical exam tells us this, and then we have to decide if it is appropriate or not to manage the spasticity. And you're saying, wait a minute, why wouldn't we? Well, in some cases, and this is an important point, the person's spasticity and spasms can actually facilitate their movement, can facilitate their function. And so I don't want to just willy-nilly treat spasticity and spasms because I can take away some of the person's function if I do that. So there is a balancing act that we have to maintain as we look at managing spasticity and spasms. Prolonged spasticity and spasms, as we talked about briefly, can cause muscle contractures. Muscle contractures are simply short muscles that occur because of that constant tone. They actually reduce the number of sarcomeres that are laid down in series to the muscle. And so basically you have a shorter, tauter muscle as we go through there. So much more on that in time to come. We know that there are significant health risks that we haven't spoken about already. So additional pulmonary complications related to exercise, obesity and metabolic syndrome related to insufficient exercise to compensate for an intake in which the person has lost some degree of satiety, that is fullness, while they're eating. Our folks are at high risk of stroke because particularly those with T6 and above spinal cord injury because of autonomic dysreflexia. Our folks are also at high risk for degenerative changes in the upper extremities, osteopenia, osteoporosis, and depression. And so I want to briefly talk through these things as we're going along. Ventilatory responses to exercise. Again, we're going to have some restrictive components to exercise. Most able-bodied individuals are not limited by ventilatory responses. They can breathe fast enough and deep enough to make sure they don't become hypoxic. Why is that necessary for aerobic exercise? You want to be able to utilize oxygen as much as possible. But after spinal cord injury, you have both this neurogenic restrictive and obstructive lung disease. And so recognize that prescribing exercise is going to be a little bit different for our folks with spinal cord injury. As well, they are at high risk for what we call neurogenic obesity. And this is because of motor paralysis, subsequent loss of muscle mass, we call obligatory sarcopenia, the sympathetic blunting we talked about with the autonomic dysfunction, anabolic insufficiency. So particularly men are going to drop their levels of testosterone and growth hormones significantly after spinal cord injury. And then we mentioned the blunted satiety that basically causes most folks to take in more energy than they're expending. And we know that obesity, increased adiposity, mediates the metabolic syndrome. We'll be having discussions on that and talking about insulin resistance, hypertension, dyslipidemia, thromboembolism, and coronary artery disease that are associated with increased adiposity. We also know that there are thermoregulatory dysfunctions after spinal cord injury, so that folks with injuries, particularly T6 and above, are going to become essentially poikilothermic. What does that mean? That means they take on the ambient temperature around them. So if it's 90 degrees, their body will drop to what? Drop to 90 degrees. This is one of those things that seems like a misnomer, but they will take on the ambient temperature around them. And I've seen folks come into an emergency department on a hot summer day with high humidity, but sitting in the shade, and with a slight breeze going across, and they actually become what? Hypothermic, despite that. And so they are also at risk for hyperthermia. And so if the ambient temperature around them, and I saw this a lot in Arizona, is above 100, they will take on the ambient temperature around them as well. They have an impaired countercurrent exchange with the blood flow. And so instead of typically in warm ambient temperatures, we try to dissipate the core temperature by shunting blood to the extremities, the skin and whatnot, and we sweat. The sweat is maybe not so much in Florida, but in Arizona, in dry, humid, dry states, you have, I just lost the term. So evaporation. And as the sweat evaporates, it actually cools the skin. There's that countercurrent exchange that takes the blood back to the core and helps cool it down. Our folks with spinal cord injury can't do that. And part of that is because of the sympathetic blunting, the vascular abilities or inabilities that occur after this. But there are also actually changes in the preoptic anterior hypothalamus that changes their ability to sweat. And our folks with spinal cord injury cannot sweat except above the level of the injury. So they don't sweat below the level of the injury. And without sweating below the level of the injury, they've lost a lot of the ability to thermoregulate. So these are issues that we need to contend with in hot, humid environments like Miami. Recognize the other side of the spectrum, however, when I was treating patients up in Michigan and Pennsylvania in the winter months, when it becomes cold, they become hypothermic and they literally slow down their speech. And it can be very disconcerting to have somebody show up in your spinal cord injury clinic speaking very slowly and you don't know what's going on. That can be just because of hypothermia. And I've seen body temperatures, at 94 degrees and even below that because of ambient temperature hypothermia. Eventually you bring them in, you warm them up, and they do warm up to you. And you can get past that. But you worry in the interim, what's going on? Are they possibly having a stroke, for example? So endocrine responses are also significantly different after a spinal cord injury. The catabolic hormones, remember catabolic hormones are the ones that go in, they break down muscle, they break down bone, they break down other parts of the system to basically allow substrate utilization during times of crisis. The anabolic hormones, however, are the ones that build back up the muscle, build back up the bone, etc. And we know that those are very blunted after spinal cord injury. So we have significant issues that we have to contend with after spinal cord injury that are new and different to many physicians who don't understand all of these changes that have occurred. We will talk about the influence of spinal cord injury on bone metabolism, recognizing that there are at least four mechanisms by which a person is going to lose bone mass after spinal cord injury. Part of it is just mechanical unloading. And in the early phases, and for particularly young men who are at peak bone mass, who have a spinal cord injury, suddenly we develop this immobilization hypercalcemia. They start dumping calcium from their bones into the bloodstream. And we talk through the whole issues associated with that. Recognize again, the hormones are going to decrease, the anabolic hormones are decreasing after spinal cord injury. That's also going to reduce bone mass. There are neuronal changes so that you don't have the neurotropic influences, but as well, sympathetic blunting is going to decrease vascular perfusion of the bones. And on the converse, autonomic dysreflexia is going to stimulate osteoclastic activity that further reduces bone. We have a reduction in afferent signal conduction. So all of those things are going to contribute. And then did I mention obesity after spinal cord injury? Adipose tissue also secretes a number of pro-inflammatory cytokines. And those pro-inflammatory cytokines stimulate osteoclastic activity, which breaks down bone. So for a number of reasons, we need to worry about this. The immobilization hypercalcemia that I talked about comes along with clinical signs and symptoms. And typically we describe this as stones, bones, groans, and psychic moans. These are the usual symptoms that we see associated with immobilization hypercalcemia. Recognizing that, again, particularly young men with high bone mass who have a lot to lose very, very quickly are going to need to be managed with volume repletion and hydration. So they have hypercalcemia. We're going to try to dilute that and ideally filter it through the kidneys with diuresis. And then we may end up using mithromycin or calcitonin as well. Ultimately, our folks are going to develop osteopenia below the levels of their spinal cord injury. And oftentimes this will move on to osteoporosis. It's not unusual for folks with spinal cord injury, paraplegia, or tetraplegia for their lower extremities to lose bone to about 2/3 of normal, which is right at fracture threshold. So they're at high risk for fractures as well. Heterotopic ossification, or the Santa Claus disease, as I call it, ho, 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 heterotopic ossification, heterotopic ossification, heterotopic ossification occurs probably because of a combination of spasticity around joints and this excess calcium that's being dumped through immobilization hypercalcemia. And essentially the person develops abnormal periarticular bone, that is bone typically at the hips and knees, and then you might see it in folks with tetraplegia up at the shoulders and elbows as well. So heterotopic ossification occurs somewhere between 16 and 50% of individuals with spinal cord injury. Oftentimes it's not diagnosed, but the person may develop not just contractures, but actually heterotopic bone that needs to be managed. Now, the management is difficult because you want to provide range of motion to try to maintain range of motion, but if you provide too vigorous range of motion exercises, it can actually stimulate the production of more heterotopic ossification. So we work very closely with our therapists, pharmacologically using nonsteroidal anti-inflammatories and the bisphosphonates. Chronic heterotopic ossification can be managed surgically. However, it carries it's a very, very bloody surgery, not just in England, but in America as well. Not just a bloody surgery, but it's also a high risk for infection. Up to 25% are the numbers that I've seen recently. So it's not something you approach lightly. And if the person has HO, but it doesn't limit function, then oftentimes we won't manage or we won't try to intervene with surgical management. Our folks are at high risk for particularly upper extremity overuse. And Dr. Vivas, one of our attendings, recently reported on upper extremity overuse syndromes in spinal cord injury, primarily related to obesity. And so we've got a number of musculoskeletal as well as nerve entrapment types of issues associated with this. And so there's a whole lecture we're going to give you just on upper extremity overuse management. We know as well that in addition to that nociceptive pain, which is typically mechanical, musculoskeletal, the The person may develop neuropathic pain, and Dr. Felix recently wrote on this. This is her area of study and her research. And so looking at neuropathic pain, either above, at, or below the level of the injury is very, very important. If it is at or below the level of the injury, remember that it can cause autonomic dysreflexia as well as increased spasticity. So finding the underlying cause, just because a person has a spinal cord injury and they may not feel the pain, if they have a significant autonomic dysreflexia or spasticity because of that nociceptive input, that can basically, as we talked about before, cause stroke, seizures, organ failure, and death in some cases. And then we worry about neurological changes after the spinal cord injury. So it's not unusual to develop a syrinx, so that you have this cavity where the neural tissue and the glial tissue basically necrosed, and subsequently you have a glial scar, but which is relatively empty except for cerebrospinal fluid. Recognize that the syrinx can expand over time. If it expands upward, it can cause a loss of upper extremity function that had still been available. And it can, in fact, go all the way up to affect the breathing centers. So a syrinx is no small issue, and it's one of the reasons why we are particularly careful to document every time we see on an annual evaluation our spinal cord injury patients. We are looking again at their sensory level and their motor function level, because if those change, particularly if they lose function, we worry that it could be a syrinx that could subsequently go on and lead to profound motor changes and profound lack of breathing, et cetera. Folks can develop hematomas. Some of our folks are on anticoagulation therapies, and that can cause a hematoma in the area. Recognize that if somebody is on, for example, Coumadin, and then they get a urinary tract infection and are treated with certain antibiotics, that can basically accelerate or auto-enhance the anticoagulation. And a person whose INR may have been stable at 2 to 3 for years now gets this antibiotic, and it can bump their INR level up to above 4 and even 5, which puts them at high risk for developing hematoma in the central nervous system. New trauma can occur, and then folks are still at risk for tumors. Just because you have a spinal cord injury doesn't mean that you can't develop a spinal cord tumor on top of that, and sometimes we forget. And then finally, everybody is interested in optimizing motor control. How can we do that over time? And so we'll talk a little bit about exercise, locomotor training for neuroplasticity and those types of things. So this is essentially where we will go over the next, I guess, 18 weeks or so. I'm, again, just using this as an appetizer today to let you know what's coming down the pike, but I'm happy to answer any questions, concerns that may have been raised because of this particular talk. Somehow I got that done in 50 minutes. I am open for questions, so feel free to put those into chat, or if you have a question and aren't too shy, feel free to speak up. You can unmute yourself.
Hi, Dr. Gator.
Dr. Vivas.
Right. So it's more of a comment, not a question.
Okay.
And I think I don't know if I'm speaking for everyone, but when we first hear a spinal cord injury or having a patient with spinal cord, we first think about the somatic system and having a motor weakness or muscle weakness. But every time I hear this type of presentation, we get to know that spinal cord injury patient, the sequela is much more bigger than just the muscles, having muscle weakness. So we have to be very careful and be paying attention to the autonomic system and how autonomic system dysfunction is going to cause many of the comorbidities in these patients.
Absolutely. I couldn't agree more. I would say, let's see if I can go back to one of my very first slides where I talked about all of these.
Yeah.
Um, this is crazy. This is what happens to a person, often immediately, but sometimes chronically after a spinal cord injury. And so say a healthy 20-year-old man who sustains, let's call it a C4 or a C5 spinal cord injury, is subsequently, and this is where I'm so grateful to have Dr. Vivas helping us teach now our spinal cord injury folks. All of these comorbidities need to pop into our mind just as quickly as motor paralysis. I agree, Dr. Vivas. And it's so important, and as our residents and fellows rotate through, as our medical students rotate through, recognizing that it's not just, yes, motor paralysis, but it is typically at least 8 or 10 additional comorbidities associated with the spinal cord injury, and with high spinal cord injury, even more than that. And so it's not uncommon acutely, and then in our clinics as well, to see a person with spinal cord injury, no previous medical problems, now suddenly has 10, 12, 14 comorbidities that we're having to manage. And that's part of the complication of following these folks up year after year, is we have to be able to take the time to address each one of these issues. And as we talked through, hopefully you realize a number of these things can actually cause significant autonomic dysreflexia, spasticity, and additional problems, additional comorbidities that can lead to death. So yes, thank you for bringing that up, Dr. Vivas. So glad to have you on board.
Of course.
All right, well, I will leave you with those profound thoughts then. It's always a pleasure. Next time, I think that we'll be talking through the INSCI examination, how to do the neurological classification for spinal cord injury. And while it is primarily geared for traumatic spinal cord injury, I'm also going to try to make a case that our persons with atraumatic spinal cord injury can benefit from having this examination as well, because it does give us some idea of their risk for comorbidities and whatnot. So hope everybody has a wonderful week. Actually, it'll be 2 weeks because I will be gone next week, but we'll pick it up after that. Hopefully a very fun and engaging discussion on neurological classification of spinal cord injury. So everyone have a wonderful day.